Hello, I'm Dan Jones from the University of Mississippi, and happy to be here with Dr. Paul Whelton from Tulane University, and importantly for this conversation, the chairman of the steering committee for the SPRINT study. And Dr. Whelton, we're here today to talk about SPRINT. Seems like everybody's talking about SPRINT right now. It's a pretty exciting time.
Very nice to be with you, and it is an exciting time.
Yeah. So before we talk about the study design and so forth, tell us why this study was organized and done. What was the important reason that SPRINT needed to be done?
As you well know, we know there's a strong relationship between blood pressure and cardiovascular risk with no threshold. And again, as you know, high blood pressure is very common. Leading cause of death and disability adjusted years. Hypertension is very common worldwide, over 1 billion adults. We know that antihypertensive drug therapy reduces the risk of cardiovascular disease. What I think for you and me and many others has been the remaining big challenge is how low do we go? How low do we take that systolic blood pressure? So that was basic research question. And
so why is it so long? I mean, we've known lowering blood pressure reduces the risk for cardiovascular disease for several decades now. Mm-hmm. So why is it taking us so long to ask this important question, how low should systolic blood pressure be?
Well, it is incremental, isn't it? I mean, these are, when you try to answer that question, it sounds like a simple question, but answering it is difficult and it is expensive. And our trial obviously took many years to plan, big trial, cost a lot of money to the taxpayer. You really have to justify doing these big trials. That's, I think, why it took so long.
Yeah. All right. So tell us a little bit about the SPRINT study design, how you and your colleagues set this up, and the important questions that you were trying to answer with the study design.
Answer that question, we did a randomized control trial, and basically we randomized to 2 levels of blood pressure control. One was the standard level. Most guidelines recommend it, an average systolic less than 140 millimeters of mercury. And the other was lower than that. It was an average systolic less than 120 millimeters of mercury. And to make sure we would have adequate statistical power to answer the question, we randomized over 9,000 participants, 9,361 to be precise. We wanted to be sure we can answer the question in a variety of individuals. So we selectively brought in about 30% who are above 75 to make sure we could look at that question in seniors. We brought in a cohort of people with existing kidney disease because it's an important question to answer in kidney disease and so on. So it was a big study. Try to get the right populations. It was performed around the United States, 102 clinics. Obviously, the NIH was the program office was there, coordinating center in North Carolina, and we were successful in getting good blood pressure separation. That occurred early, and by 1 year, we had about 15 millimeters of mercury difference in systolic blood pressure that was maintained quite well throughout the trial. And then, as you well know, we anticipated going for an average of about 5 years per participant. And one day I'm going out the door and I get a call and say, the Institute has decided to stop the study because the results are already so impressive. So after a median of 3.26 years, the Institute made the decision on the basis of advice from the Data and Safety Monitoring Board to make the cardiovascular disease outcomes known to the participants and, of course, their healthcare providers, and to stop the blood pressure intervention.
So, I think a lot of people would presume that that's a lot of blood pressure control, getting blood pressures down in the range of 120 systolic. Is an impressive feat. You must have used some big miracle, new, expensive drug to do this, Dr. Whelton.
No, it's going back to the basics, really. Making sure that we measured blood pressure properly, making sure that we provided drug, making sure we recommended the drugs that are well proven to be effective from the trials, making sure that they were used to full doses. And the amazing thing to me, then, is that at the end of the day, to get that separation, it was only one drug difference. Now, That, to me, was quite a surprise. And actually not a huge number of drugs on average, a little under 3 in the intensive care group, a little under 2 in the standard care group.
Yeah, I think a question that a lot of people had at the beginning of the study was, would you really be able to achieve that level of control in a large number of participants? And could you do it with the standard drugs that are available? And I think this is a real important message to clinicians that in this study, this was done with ordinary drugs.
Right.
And tell us about the places where this was done. Was this done exclusively in academic medical centers, or were there other sites involved in this?
No. I mean, we obviously did this across the country, so it's, you know, a diverse geography. There are academic medical centers. There are centers from managed care organizations. There are centers from private practice. It's a mix. The VA, of course, was heavily involved. So a lot of different patient care settings. And I will just say on the blood pressure reduction, it's not that 100% were below 120. And that's, you know, we have to differentiate performance indicators from what we were doing, which was to get to a goal of 120, and that's the average. And there's a big difference, as you
Yeah,
as you know.
and the achieved blood pressure, systolic blood pressure in that aggressive group was about
121,
what?
102 on average.
Yeah. So really quite impressive lowering of quite impressive lowering of blood pressure.
And consistent with other trials that have done the same sort of thing, ACCORD. One thing we know about is we can get the pressure down. The real question is, when you get it down, does it do a lot of benefit, or does it do a lot of harm, or is it some mix between the two? That's, I think, for all of us, what's been the uncertainty.
So I want to talk a little bit more about the blood pressure measurement issue.
Mm-hmm.
You made a point of saying that part of the success of the study was around the issue of measuring blood pressure accurately. So tell us what you mean by that.
Yes. Well, what I mean by that is we followed the guidelines that are recommended by American Heart Association and others. So each individual, when they came in, would sit in a room quietly, and we had a mechanism whereby they couldn't have their blood pressure taken before 5 minutes. They had their blood pressures taken, in fact, with an automated device, an Omron. We got 3 blood pressures at each visit and averaged those pressures, so no decisions were based on a single measurement. So they were carefully taken blood pressures. All the other recommendations for the patient sitting, upright, back, and so on. Just simple but very important things that don't always occur in practice.
Yeah, this was one of the big messages to me out of this study is that the goal here was to have the blood pressure in the 120 range in a carefully, appropriately measured blood pressure, not in a drive-by blood pressure measurement kind of setting, but a
but nothing different than what you would hope would occur in clinical practice.
Yes.
Good practitioners would follow exactly what we were doing.
Yes. So we've talked about the ACCORD study a little bit, and the SPRINT did not include diabetics.
Correct.
And so one of the key questions that will come from this study is how generalizable are the results, and specifically, there are a couple of groups I think that will be talked about a lot, and I know that you're involved in the guideline writing process, and we'll be careful and
As are you.
we'll be careful in how you answer my pressing questions here. But what are some of the thoughts behind how we might generalize the results of SPRINT to groups outside of that narrow group of participants and their description? How generalizable are these results going to be?
So we did exclude some people for a variety of reasons. Diabetics, individuals who had a stroke, polycystic kidney disease, because at the time we were designing the study, there were trials being supported by National Institutes of Health in all those areas. Having said that, the people who were in the trial, all over 50, They all had to have an average systolic between 130 and 180. Most of them were already on a medication, about 90% of them, and then hypertensive. And they had to have some other indication of risk. So it's a high-risk group of hypertensives over the age of 50. And when we looked at those results, they were, I think, impressive. 25% reduction in the primary outcome, which was a mix of heart attack, acute coronary syndrome that didn't evolve into a heart attack, stroke, heart failure, cardiovascular disease, death. That was the composite. So we saw a 25% reduction in that composite, and we saw a 27% reduction in all-cause mortality. And the two of those together are pretty powerful.
Very powerful.
Now, we did see some indicators of potential for adverse effects, and I suppose that's not surprising when you bring that blood pressure down. So there were some indicators of maybe some renal effects. Whether they are short-term effects of blood pressure control,
right,
or they mean something more in the long term, I don't know. We saw some hospitalizations due to, or related at least to syncope and hypotension, but we did not see an increase in injurious falls. So, over time we'll sort of sort out how much of a problem the side effects were, but our impression overall is that the beneficial effects seem to be much, much more important. And how then do we go from there? We like always when we do clinical trials to have ability to answer the question, good internal validity. And then the question is, who can you generalize to? So very strictly, you could probably say only to the people who are just like those who are in SPRINT. And maybe that's 20 million people. So sort of high risk, hypertensives who are a little older. But then it becomes more difficult. And do we generalize to diabetics? There was a previous trial, a core done in diabetics, which didn't answer the question. It didn't seem to have enough statistical power. Overall, their results, I think, would be consistent with ours. And in most trials where we've used antihypertensives, diabetics have seemed to do about the same as non-diabetics. So it's up to the individual practitioner, and I imagine the guidelines committees will wrestle with this one as to how much we generalize. Clearly, as you get down to lower risk, it's much harder to generalize. Clearly, as you get to higher risk and older people, it's easier to generalize. And of course, this is what every clinician has to do, sitting down with their patient to look at the data, see how does it relate to this individual patient, and what's the discourse. But the amazing thing to me, or I shouldn't say amazing, but the impressive thing to me was that those over the age of 75 seem to do just as well as those younger. Those with kidney disease got just the same benefits as those who didn't have kidney disease. So all those subgroups were identical in terms of the primary outcome and all-cause mortality.
All right, so let me put you on the spot a little bit. So you get a call from a clinician next week. No new guidelines are out yet. He's excited about the results of the SPRINT trial that you've presented. And so he has two patients in his office he wants to ask your opinion on. Mm-hmm. One of them is an 80-year-old that he has on 2 drugs and who has a systolic blood pressure now of 136. Mm-hmm. And the patient's otherwise healthy and stable and doing well. Mm-hmm. And so he wants your opinion on whether he needs to go further and consider lowering the blood pressure further. And the second patient is a 30-year-old with a systolic blood pressure of 130, who's completely asymptomatic, mm-hmm. has a family history of hypertension mm-hmm. and of cardiovascular disease, mm-hmm. And a family history of diabetes, mm-hmm. But has a systolic blood pressure of 130. So would you offer advice to that clinician? And if you did, what might you say to that clinician?
Yeah. Well, I'll take my guidelines hat off because at the end of the day, I think both of us will have good discussions and we'll hopefully come out of that smarter and so on. I think for the patient, the older patient, it's a matter of having a discourse. I think the sprint data would strongly suggest that there's benefit there, and this is an individual who's likely to be at high risk at that age. And so if they are asymptomatic and they're tolerating the treatment well, I think careful, judicious reduction in blood pressure, if the patient agrees, is probably a smart, wise course based on sprint. For the other patient, I don't think the sprint data will inform the decision very well. Now, it might well be that the practitioner will say, this person is facing a lifetime of risk, and I would like to get that pressure down. And I think many practitioners and many pediatricians who follow patients into that younger adult age would feel very strongly about trying to get that pressure down. Certainly the epidemiology would suggest lower is better. But I don't think the sprint data specifically will help to inform the answer to that question very well.
Let me close with kind of the last part of sprint that won't be presented at this meeting and won't be in this publication, and that has to do with data on cognitive function and then some more renal data that will come. And so when can we expect results of that analysis from the sprint study?
Well, the beautiful thing and the frustrating thing about sprint is it got stopped in the middle of the trial, or what we expected to be the middle of the trial. So that was the good news. I mean, it is good news. On the other hand, it interferes with how we do business. So instead of doing final visits at year 4 and year 5, we've had to accelerate them and get those final visits done now, which really are important to addressing the cognitive impairment and dementia question, doing MRIs to look at brain size, and as you say, looking again at renal function. So that will be finished sometime next year, and I think for us now we're prioritizing what's really important to the treating community and to the general population in terms of prioritizing next pieces of information that we get out from sprint. So hopefully we can do that. It would be very nice if there is the opportunity, and I hope there will be, to do longer-term follow-up to see what do these renal indications mean. Do they mean not much, which I hope is the case, or do they really mean that these people are in increased risk? So we will learn more over time.
Well, we'll anxiously wait the further results. And as we close, let me congratulate you and your investigator colleagues on a wonderful study that will have a large impact for years to come. Let me express appreciation to you, to the more than 9,000 participants, and to NHLBI for funding this study. So important to us in terms of preventing cardiovascular disease. So congratulations and thank you.
I just want to underscore, without volunteers willing to come into the trials, we can't do the trials. So special thanks to the over 9,000 who participated, and indeed all of the colleagues. As you say, there are 4 institutes involved, and they are outstanding colleagues, best in the world. So it's a lot of fun to work with great people.
Well, thank you for your work on Sprint, and thank you for the opportunity to have the conversation today.
Thanks for having me.